a question comes: humeral shaft fracture. Humeral fracture can come with a neurological injury. The gambit is to fix the fracture or either leave it without thinking about the neurological insult, because it's mostly neuropraxia. So a humeral fracture has different types of fractures which you can see. Halston-Lewis fracture is a common lower one-third fracture occurring with neuropraxia and the radial nerve entrapment. AO classification 12A is simple. A is simple. It's 1, 2. 1, 2. A is simple, B is wedge, and C is complex. Treatment is non-operative, include a hanging cast, functional class brace, or a plaster use splint. Sarmiento in 2000 had his 1,000 patients being conservative management and followed up to 12 years with a non-union of rate of 6% in open fractures and 2% in closed fractures. So it's a very important thing to predict. Sarmiento 2000, 1,000 patients, 12 years follow-up, only non-union in 2% of the closed fractures and 6% in the open fractures. If the fracture comes up, use slab from shoulder to axilla for 2 weeks and then a functional cast brace. Anterior posterior straps of Velcro, well maintained, reduce and stabilize the fracture with a soft tissue compression. Success depends on upright position of the patient, tightening daily, can't lean or on elbow, exercise the elbow, and can be used for distal fractures as well. Acceptable alignment for the humeral shaft is going for Kleinerman criteria: 30% varus or valgus angulation, 20 degree of flexion extension, 3 cm of shortening, and 50 degree of rotation. Operative indications: open fracture, vascular injury, ipsilateral elbow fracture, floating shoulder, floating elbow, bilateral fractures, polytrauma, failure to obtain and maintain acceptable close reduction, pathological fracture, brachial plexus injuries. Intra-articular fractures or extension, unfavorable body habitus, particularly in ladies with large breast. Plate is always better union compared to the nailing. Used with bone graft for non-union. Radial nerve is 15 cm above the lateral epicondyle. Significant torsional forces. Fixed with a 4.5 LCDCP. Parallel plating distally is more stable than perpendicular plating, but it depends on the geometry of the fracture. Regarding the eye nail, better for segmental pathological fractures. Antegrade ends 2.5 cm above the olecranon fossa. Place a pillow below near to elevate. Retrograde entry 2.5 cm above the olecranon fossa. Radial nerve is at risk with lateral and medial distal locking screws. Musculocutaneous nerve is at risk at anterior-posterior locking screws. Flexible nails can be utilized in children. Normally, the approach should be antegrade. Golscher et al., Netherlands. No evidence to assert whether surgical intervention gives better or worse results than conservative management in humeral shaft fracture in adults. Gosler et al., 2012. ORIF with DCP is the best option for unstable humeral shaft fractures. IM-NEL may be indicated for specific situations. No difference in function, but reduced complication with the reoperation with DCP. If associated with radial nerve injury is mostly a stretch injury, neurotemesis suspected with high energy open fractures, 9 of 10 recover spontaneously, follow up for 6 months, EMG should be done at 2 months, fasciculation should observe, fibrillation indicate Woodring degeneration, splintage and stretching to keep the muscles and joints supple. Monitor carefully. The first nerve to recover at the supracranial humerus fracture with radial nerve deficit is brachioradialis, and last is EIP. The first to recover is brachioradialis and last is EIP. Spontaneous recovery occurs in 4 months in 70% of the cases. Anyhow, no significant difference compared managing expectantly or exploring early. So you have to do EMG or nerve secondary studies in 4 to 6 weeks time. If no recovery, for 3 months. Explore by 4 to 6 months. Indication for surgery in radial nerve palsy. Number one, open fracture. Number two, no improvement in 6 months. Number three, palsy following a manipulation. Number four, Holston Lewis relative indication with higher chance of nerve being entrapped. Number five, high energy injury due to risk of sharp bony fragments. Nerve management is nerve repair or graft, and tendon transfer graft not possible.